when you think about how far we've come and how long we've come in our journey with COVID, from an AMITA standpoint, broadly, we're proud that one of our hospitals here locally, St. Alexis Medical Center, was the recipient of the first 2 COVID patients in the state and the second in the country. And so when we go back to March and kind of fast forward through today, here at Alexian Brothers Medical Center, we like to look at how many patients we've discharged home for safe recovery. And as we've totaled those numbers up, we are well over 400 patients that we've discharged home for a safe recovery. And so we really like to focus on that with our physicians and with our staff, and really on a positive note that really shines light on all the great care that we're delivering and we're doing. So really, as I kind of close up, just some opening comments, because I'm mindful of time and I want to really allot the balance of our time to really the meat of the agenda. I just want to thank all of the members who are here and all the folks who have reached out to us to donate your time and your food and your financial donations and your locations and a lot of the tangible items that we've been able to benefit from through our battle here within AMITA. We're appreciative. Our associates are appreciative and really just so humbled by your generosity. So again, mindful of everybody's time, we have some really neat things to walk you through and some great stories to walk you through just in terms of this journey. And so we've got a great physician panel assembled here, and I will kick it off to Dr. Luke Northern, who is an anesthesiologist here at Alexian Brothers Medical Center, and he spent some time, truthfully, on the front lines in New York and answered the call when New York was reaching out to folks across the country to come and help. And Dr. Northern put his hands up and was one of the first to respond to New York, and he's got a great story to tell. And so I will turn it over to Dr. Northern.
Thank you very much, Dia. I appreciate that introduction, and I appreciate you all allowing me to speak to you this morning. Can you guys hear me okay? Good. All right. So again, my name is Luke Northern, and I'm an anesthesiologist here at Alexian Brothers Medical Center. I'm employed by a national healthcare company, and they gave me the opportunity to volunteer in New York City during the COVID crisis. So I spent 4 weeks in April working as a critical care physician in Brooklyn, and I'll share a little of my experience of what the COVID crisis looked like then in April, and from a healthcare perspective, maybe what it's starting to look like now. So if you see here, these are pictures of O'Hare when I was flying out in early April, and there's the empty plane, and that's when I arrived in an empty Times Square. And this is just to show what it was like, what the shutdown was like, what it did to our economy, and how kind of haunting it was. So I was part of a Mount Sinai deployment through my healthcare company, about 50 to 75 advanced nurses or physicians. We went to 7 Mount Sinai locations throughout New York City. We were either in the emergency department, the ER, or the ICU, critical care. I worked in ICU. What they had us do is pretty much split up the day. So 12-hour shifts. We did 2 days on, 1 day off. You either work days or nights, and it was left to the various hospital administrators to utilize how they were going to use these human resources. And there it is. That's where I was assigned. I stayed in Times Square. However, I worked in Brooklyn. So this is Mount Sinai, Brooklyn, a 200-bed hospital, an area that was hit hard by COVID. I arrived in Times Square on a Friday night and was here on Saturday starting to work. And as you walk into the hospital, you can see this. This is the PPE station, or the personal protective equipment station. So right when you walked in, you were given your gear, and this was a COVID hospital, so the entire hospital was full of COVID patients. So right when you entered, you just presumed that every surface of the air beyond this point was contaminated. And this is what it looked like when we donned our personal protective equipment. You'll have to trust me that there's a handsome guy behind there. That's me. But we were given N95 masks, a face cover over the 95 mask, the face shield, the head covers, shoe covers, and gowns. I'm not in my gown there. But that's the way we walked around the hospital from unit to unit, and we kept that on the entire time throughout the entire shift. This is the ER, and this was the ER on my first day. And it was a picture of a hospital that was overrun. There was simply no physical space. The beds here are presumably filled up full of COVID patients, and the slots there are completely full of intubated COVID patients off to the right. I don't know if you can see those that well, but you'll notice a COVID patient at the entrance of the hospital by the computer workstation. Sorry. Right there in front of the computer workstation, and another one by the hospital entrance station right there. And there were oftentimes no beds. Once these patients were intubated or got a breathing tube placed in the ER, they would have to stay there because there was simply no place for them to go. I'll go on. So if patients were not intubated in the emergency room, and they still had to be intubated, they were intubated in floor beds if needed. Normally these patients would be transported to the ICU, but there were no ICU beds available at that time. So they remained on the floor intubated on a ventilator, oftentimes with a single nurse taking care of many patients. It was one of my duties to go around to these floor patients and assess which ones were viable enough to be transferred to the ICU or to be transferred to an outside hospital. This was a very tough job. One of the hardest tasks of my job. And this is one of the vents that we use. It's called a laptop vent or an LTV vent. And in the first few days I was there, the codes were constantly called overhead for us to come and intubate the patients or insert the breathing tubes, and oftentimes to start the chest compressions on patients. But this is what we did. We would go to the floor beds, intubate the patients, put them on this vent, and oftentimes just move right on to the next one. And this is me in the ICU rounding, and this was my main task as I was an intensive care physician at this point. So you'll see me in the middle. To my left is an intensivist, and then to my left is to my right is a nurse. To the left is the intensivist, and then to his left, another anesthesiologist. And this was called ICUB. It was their PACU or their surgical recovery area that was converted into an 11 ICU bed. So the main ICU was 12 beds, and combined with this makeshift ICU, there were only 23 critical care beds total in this patient. Easily 40 to 50 patients in the hospital were intubated and needed critical care. So to say the least, physical space and resources were very minimal. So this is a picture of a patient in the main ICU. It is a picture of what we call proning, or if we turn the patient upside down, face down, that helps with their oxygenation. That's one of the treatments that we use for COVID. But you'll notice a few things here. One is that the patient, this is in the normal ICU, so they had their own negative pressure room with the pumps on the outside to limit the exposure. And it's important for this time, I think, to talk about resources. So we never ran out of PPE. We never ran out of vents. So we were always protected. We always had masks. All the patients that we intubated always had vents, and that was kind of a big deal. And in terms of, I know in the national media, a lot of people were saying that the resources might have been down, and certainly in other hospitals that might have been the case. But there was never a shortage of ventilators, never a shortage of personal protective equipment. So I give our hospital leadership a lot of props on that. And here's a sign that you'll notice as you enter the hospital saying that there were no visitors allowed. And this is an example of how this disease deprived us of our humanity. These patients were deprived of a normal hospital course, deprived by their advocates and their family by their side, and many of these patients died horrible deaths without their family there, and that was a very sad part of our job. If we go on to the next slide, this is oftentimes what they look like when they died. This is a picture of a dead patient, and it's important to note that I hesitated very much to take this photo, and I show this photo to you not for shock value, but to document the course of this disease and show how bad it was at this time. So we put a bag over the patient's face as to minimize the exposure of the aerosolized particles to the staff as we would give the chest compressions and some meds, and that's oftentimes all we could do with these patients. And after that, they were often put in a bag like this and awaited to be put into a truck like this. And when I arrived, there was only one truck, and now you can see that there were two of these trucks out there. And since the funeral homes were overloaded, the dead bodies were moved to these trucks, and just they were on the streets and visible to the public, and just a grim reminder of how bad the disease was. But now on to some better news. This is the day that I left the hospital on April 29th. It shows that they discharged 372 COVID patients. So it's true that often the patients that I took care of that were critically ill may not have done that well, but this hospital clearly did a great job of seeing COVID patients and getting them in and getting them home. And they are already discharged close to 372 on the day that I left. So that's good. And this is a picture of my antibody screening, my results before I left. So I never felt sick, never was, however, I was exposed to the disease quite a bit. So they drew my antibodies before I left to see if I mounted an immune response to the disease, and I did not. And I think that this shows that if we protect ourselves properly, wear our mask and our PPE, that we can protect ourselves from this disease, because I was there for 4 weeks taking care of critically ill patients day in and day out, and came out disease-free, and still, to my knowledge, disease-free to this day. And there's a picture of me coming home to my family. So since I tested negative, and they met me at O'Hare, and those are my 3 kids. So just a picture of what it was nice to come home to, and I think what maybe a lot of us feel when we're separated from our family. And there's some resources there that you can explore at your own time. And go on to the next slide. And this is the transition point of my talk. So I saw this tree, and I thought it was a beautiful tree and a picture-perfect spring day in Central Park. And it seemed out of place to me as this tree was blooming on a beautiful day right in the middle of this tragedy, excuse me. And I use this as a reminder that life goes on, and that's kind of where we are now. So as I've shown, this disease can be devastating, but it's also demonstrated that by my negative test that we can reduce the transmission with the precautions that we take. So as the COVID crisis lingers on, we are realizing that certain diseases can't wait. Heart disease, cancer, many other critical diseases need to be treated before they become even more critical. And that's the goal now. As life moves on, we start to see hope. And hopefully here at AMITA, we can treat people's illnesses safely and responsibly. And with that, I will move on the presentation back to Dia. Thank you for allowing me to speak about my experiences.
Dr. Northern, thank you so much. You know, as this is now the second time I've seen Dr. Northern do this presentation, and the first time was when he had just come back from New York, and we asked him to present his experiences to our leadership team. And I remember watching the presentation for the first time, and the slide that he has in there, if you all can remember it, it's a picture of a sign that says Brooklyn Strong, and it's where they show that at this hospital there that they had discharged 372 patients. That slide really struck me and hit home for me as the president and CEO here, and that's when we really made the decision internally to shift our focus to be less about death and all the tragic things that this disease causes, and more about the positive side and how many patients we are taking care of and nursing back to fairly good health so they can be discharged home to be with their families. And so, I know I led with this, but I'm pleased to say that at this point we're well over 400 patients discharged home here at Alexian Brothers Medical Center. So Dr. Northman, thank you for that. And now we'll transition to Dr. Linwood Jones. You may have heard his voice or caught him on WGN News. He's kind of our local celebrity here. He was the first physician interviewed for a segment on WGN on what it was like to treat the very first patient in the Chicago area with COVID-19. Dr. Jones is an infectious disease physician who is the head of our infectious disease department here at Alexian, and at the time was the acting president of the medical staff of Alexian Brothers Medical Center. So, Dr. Jones, as an infectious disease physician, talk to us a little bit about what we need to know about this potentially deadly disease.
Thank you, Dan, and good morning to everyone. There's life before COVID, there's life during COVID, and there will be life after COVID. In December, nationally, we heard of this virus that was going through China, especially Wuhan, China. Didn't really know a lot about this illness, but we figured that we knew that this illness was similar to the SARS virus that had happened several years before, and this had affected Canada and China. We were sort of bracing for it. However, we really didn't think that this virus was coming to us. We'll move forward to after the holidays. Everybody's thinking about, oh, the winter's coming and whatnot. We get a call from one of the local physicians who said, I have a person who is at Wuhan, China, visiting her family, and she's coming back and she's ill. Well, that started everybody running around and lights going off and everything. We brought the patient in to St. Alexis Medical Center. And at that point, we placed the person in airborne isolation. Airborne isolation is where you have the air doesn't come out into the halls, it's blown out into the outside. And I was the infection control person there. The physicians that took direct care of the patient was Dr. Ahmed and Dr. Stoker. And at this point, we didn't know what we were dealing with. The CDC brought a team up from Atlanta. The IDPH brought a team in. Cook County brought a team in to help us. We had the patient in isolation, and we were trying to track her exposures. Later that week, we found out that she was indeed positive for COVID-19. At that point, we didn't have tests available. We had to send the test to Atlanta. So they flew the samples to Atlanta, and it took about a day for this patient's studies to come back. The CDC, the Illinois Department of Public Health, and Cook County helped us immensely during that time because no one had ever seen anything like this. And we were the first case in the United States was in Washington State. We were the second and third case in America. Now, after we saw people, this was in January, the end of January. Then we started seeing cases from the nursing homes. We started seeing cases in the cruise ships. California had cases, and even New York, where Dr. Northern was active, there weren't any cases that we had reported. We didn't know anything in January. We didn't have a test in January. However, in February, we started seeing more patients, more and more patients. They would say, well, this is coming from China. Well, then we were having people coming from Europe and they were sick. And then it came to Iran, and everybody said, oh, it's Iran. Then everyone says, it's Italy. Oh my God, it's Italy. It was Spain, it was UK, it was all of Europe. In January, we thought we were pretty smart, but we didn't know a thing. As February rolled around into March, we saw more and more cases. And Dr. Northern describes his experiences in New York. We had similar experiences at our hospitals, in Chicago, in California. If you would look at an ICU in Alexian Brothers, would look similar to an ICU in California, an ICU in Florida, an ICU in Michigan. We had the same, everybody was experiencing the same things. In March, then there was a lockdown, and everybody was trying to stop virus. We didn't have a lot of masks. We said, oh, we didn't need masks. And this was all based on a lot of data that we were slowly getting. Then we said, well, we're starting to wear masks every day. And I think the public thought, oh gosh, I'm hearing something every day, something different every day. The problem is we learned on the fly. And as more information came back, we treated patients better. We were able to protect ourselves better. We were able to protect the public. And so as we move into March and April and May, our numbers were very high. It was a lot of stress on the patients' families. As Dr. Northern said, no one could even come visit their family, and people died alone. And it was very depressing. We would have to bring people in, and we have them gowned up just to say goodbye to their loved ones. It was a terrible time. And we were having a terrible time here in New York, all over the country. We moved into June and July, the numbers started to drop. Patients weren't as sick. We were saying, well, gosh, things are turning around. Then in September, the numbers started to rise again. And along with the numbers rising, we had more issues with politics. We had more issues with patients not wanting to stay at home, not wanting to get on with their lives. Now, this happened in the United States and it's happening all over the world. We human beings don't like to be restricted. However, with public health issues, we have to think of ourselves and we have to think of other people. I sort of went through what happened to us over these past 9 months, and COVID is still with us. And I tell people, our enemy isn't public health. Our enemy is not politicians. Our enemy is an RNA virus or a ribonucleic virus that doesn't care who you are, what religion you are, what gender you are, if you're rich, if you're poor, if you're homeless, it doesn't matter. This is a virus that attacks our cells, and all it wants to do is reproduce. So at this point, what I want to leave with you is what you've heard for many, many months. Hand washing, the use of masks, social distancing, avoid crowds. That's what we can do as a citizen. And I think as we move into the winter time, I think our biggest issues will be working together instead of working in our silos. At this point, we still have to wear our PPE, and I think we have to understand that science takes time to develop. It's not automatic. It's something that over the years we've had epidemics. We had SARS, we've had MERS, which was Middle Eastern COVID virus. We've had flu. We've had the Ebola scare in this part of the world, but in Africa, it killed thousands of people. I don't remember the polio outbreak because I was a little kid. However, we went through HIV, and that was all over the world. But this is the first time in 30 years that we've had anything like this. And I think medical science is trying to understand as much as we can. One of the positive things is we have people all over the world, laboratories, government and private laboratories, all working for the same thing, trying to develop therapies, trying to develop vaccines, but it does take time. And I think our biggest thing is, at this point, I hate to be a minister, however, we need to work together.
All right. Dr. Jones, thank you. And, you know, I'll just say brilliant comments, and particularly around the personal discipline, the personal responsibility of wearing a mask, washing your hands, social distancing, the things that we've been talking about for months now are more and more important. So thank you for that. Just one other comment. I remember when the first patient came to St. Alexis, and you know the media hysteria really around all that. I remember I actually, a lot of folks who know me know that I grew up in Maryland, just north of Baltimore, and I was actually in Baltimore for a family event at that time, and I remember getting a phone call and about that, and going through the process of hustling back here to the Chicagoland and helping to deal with all the media and the cameras camped out in front of St. Alexis, and it's just amazing when you think about how far we've come since then. So, Dr. Jones, thank you again for those comments. And so now we'll transition to Dr. Michael Keller. Dr. Keller is a pulmonary and critical care physician with Suburban Lung Associates here at AMITA. He is the medical director of the AMITA Pulmonary Hypertension Program and a member of the multidisciplinary group that actually generated the COVID-19 treatment guidelines for AMITA. And so, Dr. Keller, thank you for joining us this morning. Can you walk through and explain how the evolution of treatment and the approach to COVID patients has changed in the last 7 months?
Yes, thank you, Dia, and good morning, everyone. Thank you for inviting me to speak today. So I'd like to spend a little bit of time kind of reviewing our history with this disease from a treatment standpoint. Dr. Jones did an excellent job kind of describing the progression of the disease from its onset in February to where we are today. So if you look back only 7 months ago, the WHO declared COVID-19 to be a global pandemic. I think all of us here around this table and some of my colleagues talk about how it's only 7 months, but it feels like an eternity at times. And you know, I think at that time when we were first seeing patients come into the hospital, there was a lot of anxiety and fear amongst a lot of our physicians, nurses, pharmacists, support staff, because it was a brand new disease that was scary, had a high mortality associated with it. All of our information was coming only from small clinical reports of a few patients or some really early laboratory data. We didn't really know what to expect, and we didn't have any true therapy that we knew would benefit these patients. At the end of March, we had the first emergency use authorization from the FDA, in which they gave the okay for both hydroxychloroquine and chloroquine to be used for hospitalized COVID patients. And this was based on very, very, very minimal weak data that never would have led to the approval for any other treatment in our typical process that leads to FDA-approved therapy. But this was a new and difficult time, and we were looking for something that might help to improve the outcomes for these severely ill patients. So certainly end of March and through most of April, hydroxychloroquine was used quite frequently on many of our hospitalized patients. In April, the Mayo Clinic launched their expanded access to convalescent plasma program. And Dr. Dugan, our critical care director, and Dr. Atkinson, the director of our Alverno Labs, was able to enroll all of our 19 acute care ministries within AMITA into this expanded access program. So we were able to treat patients by transfusing convalescent plasma. So the idea here is that patients who were sick with COVID-19 and recovered, that they had generated antibodies, that when they donate blood, these antibodies can be harvested into plasma, and that plasma can then be transfused to sick hospitalized patients to help to try to neutralize the virus, to help clear the virus quicker from their system, hopefully lessen the severity of the illness, perhaps lead to an earlier recovery. So that was used quite frequently here at Alexian Brothers and throughout the AMITA system. When you move forward into May, on May 1st, we had another emergency use authorization from the FDA for the use of remdesivir. So remdesivir is an IV medication that works to slow the replication of the virus. And this emergency use authorization came from the preliminary results of a well-done randomized trial, but the trial had not been fully completed. It was a preliminary analysis, but it did show a significant benefit for hospitalized patients requiring oxygen therapy. There's certainly a lot of excitement about this. It made a lot of news. The problem in early May was that the supply of the drug was incredibly limited, and the distribution was dependent on the federal government deciding which parts of the country needed the drug more. So we had an effective therapy available, but it was in such limited supply. It took us several weeks to have an adequate supply to be able to treat patients here. When we move on to June, we had the release of another trial with some promising results, and that was the recovery trial, which is a large multi-center trial conducted in the UK, in which they showed that treating certain patients with steroid therapy improved outcomes and lowered mortality. So the thought behind this is that at some point in this illness, the immune system may become overactive to the point where it's actually damaging the body, and it's not just clearing the virus. And so by using steroid therapy, you can block that overactive or hyperimmune response, lead to less organ damage and to improved outcomes. And this was a big announcement because up until this point, steroid therapy was still somewhat controversial. There were people within our institution throughout the country that felt there was true benefit. Others were definitely more hesitant, given experience with steroid therapy and some of the other pandemics that Dr. Jones mentioned, like the MERS and the SARS-CoV-1. Also in June, so about 3 months after the first emergency use authorization for hydroxychloroquine, the FDA then revoked that, because by that point there had been enough randomized trials completed with adequate data saying that there actually is no benefit. So the first drug that was used on many of these hospitalized patients was then revoked and is no longer used and no longer considered part of our treatment regimen. If you move ahead to August then, we have the news about the convalescent plasma. So the Mayo Clinic put together their data, several thousands of patients that had been treated with plasma. They put their results in a preprint article that became available to us and to the public. And then we had a little bit of a political nightmare. We had some incorrect statements made about the potential benefit of the therapy, and statements made by people in high positions in the FDA that created a pretty big controversy. But what the results from that Mayo Clinic data showed is that if patients are treated with convalescent plasma early on in their disease course and early on in the hospitalization, and if that plasma has a lot of antibody in it, has a really high titer antibody, they might have a better outcome. Their disease duration might be lower and their mortality might be lower. But again, this was not data that was acquired through a randomized controlled trial. And so there's been some limitations in terms of how much of a benefit we can really, apply to it. There are randomized controlled trials ongoing, so hopefully we will have an answer for that in the near future. So given that, we were facing a new disease, we didn't have proven therapies, it's taken months to complete randomized trials. We recognized early on that what we really should be focusing on with a lot of these hospitalized patients is optimizing our best supportive care. One of those areas has to do with complications including blood clots. So we recognized and others recognized early on that this disease can cause a lot of inflammation within the blood vessels. And it was critical to sort of have a low threshold to look for problems within the blood vessels within the circulatory system, and to be sure that we had a protocol in place to try to prevent these. So at AMITA here, we formed a multidisciplinary group with physicians from our pulmonary critical care teams, hematologists, cardiologists, and pharmacy to come up with a protocol that went out to the entire AMITA system to help address this issue. Our approach to providing respiratory support for these patients certainly evolved from early on in the pandemic to where we are now, in providing enough oxygen support through either lower high flow nasal cannula systems all the way up to pressure masks with the BiPAP or the ventilator with the pictures that Dr. Northern showed earlier. Patients who have the most severe form of this disease develop a condition called acute respiratory distress syndrome, which we've known about for years. We've cared for patients with ARDS from multiple different causes, including other viral pneumonias, bacterial pneumonias, trauma, acute inflammatory conditions. And there's two primary interventions that have shown benefit in patients with ARDS. One is making sure that we aren't harming them with the ventilator, that we're giving them just small amounts of air through the ventilator. And the second one was utilizing prone positioning. Dr. Northern showed a picture earlier of a patient in a prone position while on a ventilator. And an issue that's developed, or a treatment that's developed within COVID, is the use of prone positioning for patients who are not on ventilators but requiring high flows of oxygen, which allows us to improve the amount of oxygen delivered to these patients. So where do we stand today? So currently there are no FDA-approved COVID-19 specific therapies, only those therapies with emergency use authorization. There are over 350 therapies that have been reviewed and granted investigational new drug status. I would say right now we're in a more comfortable place than we were 7 months ago. We have two therapies, remdesivir, which works to help block replication of the virus, and dexamethasone, or steroid therapy, that works to help prevent the body's immune system from damaging itself. These are both available, widely available throughout the AMITA health system here at Alexian Brothers, and we do believe that these are improving our outcomes for our hospitalized patients. There still remains no recommended therapy for outpatients with COVID-19, which is the large majority of the patients with this illness. We don't have a treatment that helps to reduce their duration of symptoms or to prevent hospitalization. So if we look ahead to the future, what are we excited about? Certainly vaccine development, which hopefully over the next several months we'll be learning of at least a couple of the candidate vaccines that have proven both safety and efficacy, and some excitement regarding some of our antibody-mediated therapy. So monoclonal antibodies have been in the news a lot recently. There are at least 2 different phase 3, which is the last phase of the clinical trial, ongoing, that could lead to the authorization and use of monoclonal antibodies, which would work similarly to convalescent plasma, and that the antibody would help to neutralize the virus early on when people are infected, to prevent disease onset or to lessen the severity of the illness. And then the final point is also echo what Dr. Jones mentioned, is that, although we're in a better spot now than we were 7 months ago, the efficacy of our treatments is not an incredible game changer. The importance of disease prevention social distancing, masking to prevent spread of the disease and preventing people from being infected is really what our focus should be on. And so with that, I'll conclude the portion of my talk and turn it back over to Dia.
Great, Dr. Keller, thank you. And you know, I think your comment is spot on, where you said we're in a more comfortable place than we were 7 months ago as it relates to this disease and potential vaccine development. And obviously we've heard a lot about that in the media and in the news, and so hopefully in the next several months we'll know more there. So thank you for those comments. We've got about I think 40 or so folks on this call, and you know, I kind of opened this up by saying I'm mindful of time, and you know, we want to certainly leave room in the end for questions. But as we wrap up, I'm going to turn things over to Dan Doherty, who's our Chief Operating Officer here at Alexian Brothers Medical Center, and he's going to talk to you about just you know, a lot of the things that we've put in place and been doing to make the hospital more safe for patients and for folks to return to the hospital. So Dan, I'll turn it over to you.
Yeah, thanks, Dia. Good morning, everyone. Thanks for having me here. You know, it's interesting listening to the presentation that we've been going through over the last half hour or so. You know, as I kind of track this from an administrative perspective, you look back 7 months ago to the world that we lived in. You know, I've told this personal story, but 2 weeks before we shut the hospital down to visitors, I was actually in Disney World with my son, right? So you think about 7 months plus 2 weeks, you know, we were safely walking around without masks with hundreds of thousands of people or however many people are in Disney World on a daily basis without a thought. I remember a woman coughing in line as we were in line for the Haunted Mansion. And we sort of looked at each other and joked and said, oh, I hope she doesn't have COVID, right? And 2 weeks later, the week of March 13th, we very quickly made some changes here at the hospital, and we shut things down to visitors. We canceled our elective procedures. You know, we tried to respond in real time in the same way that the rest of society did. You know, we've certainly faced daily challenges. We're learning updates from the CDC at the same time as everyone else on CNN or wherever else you might have heard your news. And so there's a challenge on how do you respond to information? What's real? What's opinion? How do you change? How quickly do you change in response to new information? You know, all the things that Dr. Northern talked about in terms of could we get access to masks, the right types of masks, ventilators, medications for treatment at the same time that everybody in the United States and truthfully everybody around the world was trying to get access to the same types of supplies and equipment. And, you know, did we have enough of that for everyone? So, you know, things have changed quite a bit since then. I think as we've talked about, you know, we saw a peak sometime in mid-May. And as things began to come down off of that peak in June, we started to talk about how could we open the hospital back up to patients for non-COVID reasons, right? For everybody else out there who needed normal medical treatment, they needed access to labs and MRIs and CAT scans, they needed to go see their doctor, they needed to come in for an elective procedure that they had been putting off. Roxanne here, who was pregnant and has since had a beautiful little baby, you know, how do we care for her and allow her husband to come in and be a part of that experience? And all of those challenges, you know, were things that we had to adapt to. The world had changed, and we needed to find a way to open the hospital back up, but to keep all of our patients and our visitors, our nurses, our doctors, our housekeepers, to keep everybody safe. I think we've, as Dr. Jones has referenced, we've learned a lot about the disease, and so, you know, we've done a lot of things over the last couple of months to make this a safe place for our patients to come and get medical care. And we recognize the importance of not just getting medical care, but also getting preventive care, you know, getting your mammogram, getting your colonoscopy. It's not just about the urgent medical needs of patients. It's about that sort of normal routine care. And so, you know, for those of you that haven't been into Alexian Brothers or one of our hospitals, let me just give you a quick rundown so that you feel comfortable with, what's happening at your local hospital. But, should you come in today, should you walk through the entrance the way that we did, you'll get your temperature taken at the front entrance. There's a list of questions that are posted that you're asked about in terms of whether or not you have any symptoms of COVID. We screen every single employee and doctor that comes in to the hospital on a daily basis. We also ask them to be very mindful of any symptoms that they may have, and that they call off if they're not feeling well. We provide them with access to COVID testing should they need it. We've installed glass partitions at registration and at our front entrance. Every single person is required to wear a mask at any time that they're in the building. We have hand sanitizer stations that we've added at every corner and nook and cranny of the hospital that we can. We've instituted cleaning of all of our public waiting areas every 30 minutes. At night, we have our housekeepers go around and we have a fogger, which is a disinfectant, and we spray it in all of our waiting areas so that we cover every single surface, and we do that every single night. And, and then the last thing I would say is, and some of you may not be aware of this, but if you're in an operating room, if you're in an ICU, you're in a procedural area, you're in the hospital, we have advanced ventilation systems here at the hospital that turn air over more frequently than you might see in your general public, restaurant or other areas. And so, so we have done everything that we can to make sure that our visitors and our patients are safe. But we also, Dr. Northern talked about COVID patients who are, on their deathbed, right? And so we want to try to honor and allow for family to be a part of that grieving process. And so, we have allowed for visitors. We've put protective equipment in place for those folks, but, we recognize the importance, and not just for our COVID patients, but, for our everyday patients who are at end of life. And so we've adapted as much as anyone else, and we've gone through this journey, and we feel very confident in the safety of the environment here at the hospital, and we'll continue to do everything that we can to keep everyone safe. But I do want to say thanks to everyone, to our physicians, our physician panel. This has been tremendous hearing from you guys, and so thank you for that. We have some time left here, so I'll turn it over to Dia.
Yes, Dan, thank you. Thank you for that, and it's interesting to see just from day one through kind of day now, just how far we've come. I continue to say that. And we certainly have put a lot of measures in place here at the hospital and across all of our AMITA locations to make sure that the public knows, you all as the public know, that it is safe to return to the hospital. I also echo Dan's comments, and thanks to our physicians on the panel today. The other thing I would say, just as we kind of close out, and Lisa, I'll turn it back over to you. Just kind of my last comment as I think through this journey we've been on, I wouldn't be me if I didn't say or I didn't articulate just the impact that this has had on our staff, on our associates, on folks on the front lines, and I don't know, just a few weeks in, it really dawned on me. The level of importance of managing the emotional side of what this disease is doing to the staff and to the folks on the front line is just as important as managing whether we have the appropriate PPE. And there's so many stories of nurses who are FaceTiming with family members of patients as the patients are dying there because the rules, we had appropriate rules in place where families couldn't come in and be with their loved ones, and so many emotional stories of whether it's a respiratory therapist and managing the patients through their last breath, or whether it's one of our housekeepers who just through the process of cleaning the room has contacted or contracted COVID. Just a lot of the emotional stories that come out of that, and kind of the domino effect of managing that has really taken a major toll, not just on our staff here at Alexian Brothers, but really you hear these stories just across the country of folks on the front lines. And so from the chair I sit in, dealing with that and making sure that we've got the appropriate resources and the folks for these, our team members to talk to, and making sure that we're there for them is equally as important as making sure that they've got the right PPE. And I will say that I've appreciated the way the community has embraced our hospital and put your arms around our team here. It's really been impactful, and so noted. So thank you for that. And Lisa, I will end it there and turn it over to you. And I know we may have a number of questions out there, and so being mindful of time, I'll open it up to you.
Thank you. I appreciate it. Yeah, I have been compiling some questions that have come in. The first one is, I believe, for Dr. Jones, and that question is, what is the probability or risk of recontracting COVID?
The short answer is, I don't know. We've had several patients throughout the world who have, they've documented that they've had recurrence, and that's my, many patients will ask me, well, doc, can I get this again? And we really don't know. We're starting, a few months ago, we had the first case in Hong Kong, which was a documented recurrence. There have been several cases throughout the world. I think, I may be wrong, but I think it was in Nevada, had a case of a young 25-year-old person who contracted the illness in early spring, and then again in June or July. They thought this was possibly a different strain of COVID at the time. So the answer is we don't know. I think that we need another need another several months to know if we're really having recurrences.
Good question.
Thanks. There's another one as well. I believe this one's to Dr. Keller. And when do you think there'll be a vaccine that will be available to the general public?
I think I'll start with the same answer, which is I don't know. I'd be curious to get Dr. Jones' input on this as well. But I think the important point to remember with vaccine development is it's critical that we document safety. Unlike treatments like hydroxychloroquine that were given emergency use authorization, that authorization was given because we had thousands and thousands of sick patients in the hospital. And we were going on limited data with the authorization for a treatment that we thought might help them. But when you're administering vaccines, you're administering them to healthy patients. So you need to be absolutely certain that the safety profile is there and that it is efficacious as well. If you vaccinate hundreds of thousands of patients with a vaccine that's not efficacious, you're going to have a lot of people lose their, they'll stop wearing a mask, they'll stop social distancing, and they'll have more of a false sense of security. So I think I would say right now I don't know. Hopefully it's, we'll have something within the next 6 months or so, but I'd like to get Dr. Jones' input on that question as well.
Well, that's always a main question that people ask. When is there going to be a vaccine? Is it going to be before November? Is it going to be before January? No one knows. Now, the polio vaccine took several years to develop, and Ebola vaccine took several months to several years to develop also. And so the smallpox vaccine took years. I think this is the fastest that we've tried to bring vaccine to market in our lifetimes. And really medical, in the days of medical science, this has been the fastest that we brought vaccine to bear on a disease. So this has been incredibly quick for the for the public, they say, well, gosh, why can't we get a vaccine? Well, it takes time for science and technology to develop. I do say something about vaccines. We talk about COVID vaccine, but I would just be happy if people would take their flu vaccine this year, okay? Because that's going to be an issue. So we have a lot of people who don't want the flu vaccine, who don't trust the vaccines. Are there problems with some vaccines? Yes. However, that's why our children live to be adults now, because we have vaccines in our lives.
So somewhat related to that question, but somewhat detailed as well. And that is, will we see a spike in cases, COVID cases this winter? Specifically, the Australian Centre for Disease Preparedness did a study showing that the virus can remain on surfaces for up to 28 days in cold weather, when warm weather only allows it to stay on for about 24 hours. This was apparently just published on October 7th in the Virology Journal.
So will we see a spike?
Well, yeah.
I mean, I think one of the problems is we're getting information from a lot of different sources. And even with the Australian study, that's a small study also. And it's very difficult to predict how things are going to happen over these next few months. We've gone from something being on surfaces for 2 days, 3 days, 7 days, 24. I think we need more data.
I think within, just from an administrative perspective, certainly within AMITA, we are preparing for a spike. We're preparing for kind of what I think a lot of folks, or most folks, assume a next air quote wave will be. We're preparing for that. If you couple kind of COVID with what Dr. Jones just articulated, related to the flu, and just the normal flu season. If you couple that with COVID, we're preparing that we'll see a spike. We don't know how large that's going to be, or how impactful that's going to be, or when you compare it to kind of the first wave, the difference. But we feel like it's coming, and we're going through our process of preparing for that, which takes me back to the points that Dr. Jones made earlier, of wearing a mask, washing your hands, and social distancing, right? So those are the basic kind of fundamentals that we just always go back to the basics of reminding folks that this is the time that we're in. Wear a mask, wash your hands, and social distance.
Thanks. I have 2 more questions and a statement thus far. I'll do the statement. I don't know if it was sent to me privately, so I'm going to just read it. Thank you, doctors, for your service, for showing up for us as human race, team human. I honor and appreciate how all of you reminded us today to focus on what we can control versus what we cannot control. All the love to you and your families.
Thank you.
Very nice.
Thank you.
And then another question is about testing. When do you anticipate it will be available broadly to the public with quick results?
Well, there's, before, I say, months ago, the results took hours. Even with our PCRs, took hours. Now we are developing, not we, but over the in many countries, we're starting to develop rapid PCR tests. I think Mayo Clinic has one that can turn over in a few minutes, but that's very difficult. You can get some centers that can do this, but to put it on millions of tests, it takes time to do that. I think we know more about the test and the availability of the test in the past 3 months than we have ever. So I can't give you a timetable, but we are developing tests that are more rapid, and you want a rapid test because you can isolate patients, and can track patients.
All right, thank you. Then we had a question regarding, oh, the question actually just popped up. Where do you recommend we go for accurate information in regards to COVID?
Yeah, it's a good question. There's a lot of information out there, some definitely more reliable than others. I think the sites that are put together by our public health experts, infectious disease doctors, our physicians, locally, the Illinois Department of Public Health website, idph.org, nationally, information that's put out by the NIH, the National Institutes of Health, they keep frequently updated recommendations in terms of testing and also treatments that are geared more towards treating clinicians. And so, yeah, I think I would use primarily public health-based websites.
Yeah, I agree. One of the other things is a lot of the universities, from University of Illinois, Northwestern, the Massachusetts General, a lot of the universities and top-tier hospitals also have information that they will present to the public, that the public can obtain also. I think that's the problem is, along with the science, you get the pseudoscience and you get people's opinions and whatnot. So it's very difficult to know what's what. But as Dr. Keller said, I would go with the health department and university website.
Great, thank you. Now we had a question on what is the toll getting the virus takes on the lungs, and what are the future implications of a person who survives?
Yeah, that's a good question, and those are issues we're starting to see now as more and more patients are discharged from the hospital and surviving critical illness. So the question is, will there be a permanent loss of lung function? I would say right now we don't know yet. We don't have enough time. We don't have enough patients that we've followed. If we look at previous studies with patients who developed the most severe form of this illness, this acute respiratory distress syndrome, we do see that a number of them have a reduction in their lung function, but often it normalizes within a period of 6 to 12 months. There are not many that are left with permanent scarring or fibrosis, but the symptom that does persist and can last for years is a reduction in their exercise capacity. Surviving a critical illness with acute respiratory distress syndrome leads to a significant weakening of the muscles that can persist for many, many years. We're seeing that quite a bit in our COVID patients, even in some who are not hospitalized with severe disease, but continue to have persistent reduction in their exercise capacity, fluctuating degrees of fatigue and muscle weakness. And so I would say at this point, that is probably the most prevalent and concerning long-term symptom that we're dealing with. But we will be able to, report more, a year from now as we've had more time to follow these patients.
In addition to the lungs and muscles, what about the lingering brain lingering brain fog issues?
Well, I've had lingering brain fog for many years. I know what you're saying. This illness attacks not only lung tissue, vascular tissue. People have had young people have had strokes, vascular issues, clots, everything from, say, stroke and I can't breathe to I can't taste. And the problem is sometimes people will say, well, Doc, is it just something wrong with me? Or do I really have problems with this quote unquote brain fog? It's difficult to know, but just seeing patients will tell you, Doc, I can't concentrate like I used to. And the question is they want to know if is it psychological, is it just me, or is it really the illness? And I don't think we we know. However, I have a lot of patients who will have those complaints, and I take them seriously because it's not it's not a hoax with that. People really have these ongoing symptoms that we don't always understand.
All right, thank you for that. So surgery, is it safe to have surgery?
So I can touch on that. I'm an anesthesiologist here, and I kind of will take you back to the end of my slide, and we showed that tree, or I showed that tree, and the tree just continued to bloom, and that was a symbol of life goes on. And for better or worse, life goes on. Heart disease still persists, cancer still grows, gallbladder disease still develops, and life goes on. And we need to start to deal with life, especially now. And for all the reasons that Dan has touched on in terms of the safety, we test every surgical patient, all of us wear masks, we screen ourselves, we screen our patients, and I think that it can be done. Well, you know, nothing is 100%. I have certainly seen what happens if you delay surgery. I'm a heart anesthesiologist. If you delay heart disease, if you delay cancer surgery, if you delay gallbladder disease, there is a significant risk in that. And I guess the best way to put it is that would I subject myself to myself or my family to surgery if I thought that they needed it? And the answer would be absolutely. I would not delay any type of serious surgery or any type of surgery at all for that matter. I believe that with all of our precautions, it's very safe.
Thank you, Dr. Northern. And it sounds like those annual exams, the testing that you would generally get annually, you should continue on with, correct?
I would agree 100%, yes.
Any other questions from anybody? I think I hit all those private ones that were sent. Feel free to unmute yourself if there was another question for the doctors, but I want to truly, Dr. Northern, Dr. Jones, Dr. Keller, Dan, Dia, thank you guys so much for being here and sharing your morning with us and providing this information. It's wonderful to have somebody so local right here in our community doing such incredible work for individuals, families, and businesses. So thank you so much. And of course, in the chat, nobody could ever forget Roxanne Pratik.
That's right.
Nobody
well, Lisa,
at all.
Thank you for this opportunity, and thanks to everyone who has called in and asked questions. I think it's so important to kind of get this word out there. You know, there's so much we don't know about this disease, but then there's so much we've learned about it. And so, you know, I think we have a great story to tell here within AMITA, and as so many hospitals and health systems do. So we do appreciate the time this morning, and I think this was fun.
Yeah, thank you. And I think Dr. Jones said it. I may put it in quotes, underlined it numerous times, work together. And more than ever. And we really, really appreciate AMITA being really our hometown hospital here and providing all this information to us. I did want to send along, we did have a raffle from Harper College. Christina, did you find a winner for your raffle prize there?
Yes, I did. So Ron Roberti is our winner today.
Congratulations, Ron. And do you want to share a little about what's happening?
Yes, definitely. So related to this presentation, which was wonderful, contact tracing is something obviously that's coming up to mitigate the spread of coronavirus. So we, this last summer, Harper College Continuing Professional Education developed a 4-week course. It's been free so far. It's completely online, and it really introduces the coronavirus as the disease, the communication tools, the research, the outreach to the contacts, and as well as connecting people to resources in the community to help them. So we're offering that course one more time this fall. It's for free again, and that's November 2nd through December 6th with a break over the Thanksgiving break. And yeah, we hope that some of you would be able to join us for that. We've had all sorts of people take the course, from nurses to business people to people wanting to change their careers. because it's really being used in a lot of places where it maybe wasn't expected. I thought it would be primarily in healthcare, but of course now schools are starting to do that, and some businesses, just to mitigate risk and to know, what's going on in their organization. So definitely would welcome you. If you want to go to the website, it's harpercollege.edu/pro. And if you go to upcoming courses, and you can also just email us and we can help you get registered. And from the last meeting, as a reminder, we still have our Moving Forward Scholarship, which is also related to COVID. So anyone who's been negatively impacted by COVID, we're offering basically all of the continuing professional education courses we can have tuition applied to those courses. So really trying to help the community pick up again economically as well from a training standpoint. So thank you again for having me and for supporting Harper College.
Absolutely.
Let me know if you have any questions.
Thank you, Christina. So wanted to also, this slide that's been on the screen for a while here, Coffee and Contacts that we're having October 22nd. It is going to be a mix in person and virtual. So we have Ben Olson presenting how to make lemonade out of dirt, which essentially is wrapping up 2020 and how to make the best of things and be creative. And that's going to be at Fairfield Inn and Suites. So all of our in-person events are adhering to the IDPH as well as the CDC guidelines. So Coffee and Contacts will be at the Fairfield Inn and Suites. They do have a wall of windows that will be opening it. We are also only having about 40% capacity of the overall space. So every attendee will have their own table, 5-foot table, and it's a BYO. So stop by one of the local restaurants, pick up breakfast, pick up coffee. Now more than ever, let's support local, really show up and make a big difference in our community. So that Coffee and Contacts, October 22nd, we do have the in-person option. We also have a virtual option as well. So lots of different opportunities to network and meet more members of the association there. And then the Toast of Schaumburg next Friday already. Toast of Schaumburg, you can either show up in person to one of the 6 locations, or there is a virtual option there as well. Everybody will have their own Toast of Schaumburg glass to make the official toast with wherever you're celebrating. And while the toast, you can show up starting anywhere from 6 o'clock, the actual show, which means when we start presenting of the awards, will start at 7, end around 8:15 or 8:30. There will be dinner service throughout. And I was just informed over the past hour that the app is live. So if you go to Google Play or the App Store and you search SBA Toast, you will see our app, which this year the theme for the Toast of Schaumburg is Illuminate, to celebrate the resiliency and ingenuity of the Schaumburg business community, which we're seeing every day in every industry. So want to thank again AMITA Health for being such a phenomenal community partner. Congratulations again on your nomination for the Brian H. Burke Business of the Year Award. And we'll find out next Friday who those winners are. We hope to see you in person or virtually sometime next week. And as always, let anybody within the Schaumburg Business Association know if we can help you.
Thank you all for everything.
Absolutely, Roxanne, thank you for everything. Absolutely. It's been wonderful. Have great days. That will wrap up. If we can end the screen share, we can kind of see everybody one last time.